Okay, it says we're live. I trust that that's true. If you're here and want to give me a quick chat or a thumbs up, and I'll know we are live and that you can hear and see me okay. And I'll also jump in with a little bit of an intro to our topic today. Awesome. Thank you. Thank you. Okay. Awesome. So I know that this topic can be really dense, and as I dove into it, I realized how much information is out there on the DSM and its history and how we got here today. I don't think many of the things that I looked at and researched, I don't think that my program actually taught me. So this is what you didn't know about the DSM because likely your program also did not teach this to you. Maybe you learned it in a site for like practicum or internship, or maybe while you're working towards your full license. Hopefully, you had a supervisor who helped you with this, or you have a supervisor who's helping you with this. But there's so much information about what is arguably an important book for our field that we don't really know a whole lot about. So, I'm going to start with the historical context of kind of how it came to be, talk a little bit about the purpose and the early development and use of the DSM, and then we'll kind of move into like how it's being used now, how it's being updated. I don't know if you knew this, but it gets updated every year. It's not just about those big revisions and those big new versions that we get every so often. Every year they put out updates to the DSM, and sometimes they're very minor and sometimes they're major. So we'll talk about those, where you can find them, who does that. And then we'll also talk about ethical and cultural considerations when you're using the DSM in your own practice and with clients. Um, there was a question that someone asked about the function of Z codes, so I will also go over that. What are they? When should we use them? What are the benefits? Are there any consequences to not using them? So we'll talk some more about Z codes as well, because I think we're often so focused on the F codes or the diagnostic codes, we forget that there's a lot else that is in the DSM and that goes along with the DSM, and the Z codes are one of those. I do want to give a little bit of a context or content warning, that I will be using some quotes and naming things exactly as they were back when the DSM was created or being created. So the word of insane is used in some of the language around like who created the DSM and what it was for. So I just want to throw that out there. It's the name of like the manual originally and the context of where the manual was used. So I wanted to kind of give that disclaimer before I dived in too deep and you're like, where's this information coming from? Like, what are we talking about? So the DSM is created and maintained by the American Psychiatric Association. The American Psychological Association and Psychiatric Association both are generally called APA. So I want to be clear about which APA we're talking about. It's the American Psychiatric Association. And that probably gives you a little bit of a hint into some of the potential concerns with the DSM, because it's psychiatric. It's at times heavily based in medication and the use of medication, and I'll get into that, but just know that that's where it's coming from. That's kind of who created this and who maintains it. And something else that I think we're often not taught a lot about, or maybe near enough, is that the rest of the world doesn't really use the DSM that much. I know that the APA, if you go on the website, it's going to say that it's widely used. And yes, maybe it's used in different instances like research or, yeah, primarily research. But for us here in the United States of America, we're using the DSM not just for research, but also for diagnosing. The rest of the world, for the most part, uses the World Health Organization's International Classifications of Diseases, or the ICD. If you have been billing insurance, you probably know a little bit about the ICD. The United States of America is currently using a older version of the ICD than what the rest of the world is using right now, which creates its own complications because the United States kind of uses the ICD in the way that it wants to regarding like the codes that it has. But as far as the actual diagnostic criteria, we're using the DSM. So that's probably another training for another day. Like, what are the differences and why? But just wanted to let you know that the DSM is primarily here in the United States of America. It is not as widely used for diagnostic purposes as we might have been told. So, this is a direct statement from the most recent update to the DSM, which was the DSM 5 TR or text revision. It says that the DSM is to assist trained clinicians in the diagnosis of mental disorders as a part of case formulation assessment that leads to informed treatment plans for individuals. So that is just a statement about what the DSM, the APA is hoping we'll use the DSM, is to help with diagnosis as a part of case formulation and assessment, and therefore informing our treatment plans for each individual client that is presented in front of us. So, what does the DSM include? It obviously has a diagnostic criteria. It also has diagnostic features, so how to use the criteria, as well as some points on how to interpret criteria when they show up. Associated features with various diagnoses. These are clinical features that maybe are not a part of the formal diagnostic criteria, but they do often co occur with that particular disorder. And that's another word that is often used interchangeably, disorder, sometimes disease, sometimes condition. So you'll hear that as well. The DSM, as it's noted, Diagnostic and Statistical Manual, does have quite a bit about statistics. And really, what they're talking about is the prevalence or the rates of a certain condition within the community as a whole. And just be aware that statistics often, as someone who loves statistics and has done research, are often not that great because of the way that they are gathered and the way they're disseminated. So please take these statistics with a huge grain of salt, and just know that it's not set in stone, whatever the statistics say. It is ever changing, it's ever evolving, and hopefully ever improving. But that's, again, another training for another day. They talk about the development and course of particular conditions. What are the lifetime patterns of the presentation? How might it evolve over time or over the course of a lifetime of an individual? So, this can include typical age of onset, some of the early subtle signs and symptoms that may show up, signs and symptoms that are gradual or may go unnoticed, signs and symptoms that can just kind of occur randomly or abruptly. It talks about the difference between an episode for a particular condition versus something that would be persistent or even recurrent episodes. The duration of symptoms or episode, and that I think also gets back to kind of the minimum criteria for a diagnosis. The progression of severity and associated functional impact. So when we're talking about functional, we're thinking like their daily lives, education, work, home, independent living, social. These are all areas of functional consequences from these conditions. Risk and prognostic factors, so temperamental, environmental, such as trauma or substances, genetic and physiological, so maybe familial patterns, things that show up in genes, but also maybe not necessarily in genes, but it shows up as like a pattern within families. There are sections under each diagnostic category as well as each diagnosis related to culture, related to sex and gender. They often include association with any suicidal thoughts or behaviors. So that's not its own diagnosis as of right now. Just having thoughts of suicide or suicidal behaviors, that's not its own diagnosis right now, but it is associated with certain diagnoses. And so they talk about how it is for each one. Of course, they talk about the functional consequences of each condition, any differential diagnosis. So maybe you think it's this, but it could actually be this. Just a general example could be under OCD, they talk about how some of these same symptoms could show up as generalized anxiety disorder. And then comorbidity. So maybe for this one, an example would be like depression and anxiety often go hand in hand. So, what are the rates of comorbidity for two or more conditions to occur together? When I said dense, I really meant dense. All of that is included under each diagnostic category and under each diagnosis. They've got all of this listed. So if you're used to just going to the criteria and not really looking any further than that, I would highly recommend going in and checking out that additional information to see what they're saying. I'm not Don't take it as set in stone by any means, but it's just good information to have of like what patterns or themes are being found about the various conditions. So let's talk about the history of the DSM. And there was a point in time when there was no DSM. And what was actually happening in the United States of America was the Bureau of Statistics started to gather demographic data. And this was in 1840, where they tried to regulate the treatment of people with mental illness who were institutionalized. So it wasn't so much about what a diagnosis is, what the criteria was. It was more so trying to gather census data on individuals who were institutionalized, so forcibly put into like a hospital type of inpatient. They're not as common now because that's a whole another training on the laws that went into place to deinstitutionalize a lot of those systems. But at one point, there were many individuals who might not have counted in the census because they were in the institutions. So it really wasn't about trying to diagnose anyone. It wasn't even about trying to calculate the number of diagnoses. It was more so just trying to gather a full picture of individuals. So the APA was originally called the American Medico-Psychological Association. I had to look at that because that's not an easy thing to remember. The American Medico-Psychological Association. So that medico and psychological eventually combined into psychiatric care. And they originally created the Statistical Manual for Use of Institutions for the Insane. And so that's where I was talking about how the word insane was used, was institutions for the insane. So again, this was going beyond the census of just trying to count individuals, but starting to actually categorize them by diagnoses or diagnostic categories. And there were 22 at that point. There are way more than 22 now, but at that point, the majority of them, of those 22, were related to psychosis. So think very small, like number of diagnostic categories, not even really getting into full diagnoses until the first edition, which was in 1952. That is not that long ago, really not that long ago that we had the very first edition. It was skinny, it was short, it was spiral bound. Can you imagine the current DSM being spiral bound? And there were 102 diagnostic categories. So just in that first edition, we grew from an original like 22 categories into 102 categories with the very first edition of the DSM in 1952. They did note in the histories that I had researched that with this first DSM, there were significant discrepancies between what was written in the DSM and what was written in the ICD, which at that point was version 6. So in 1952, there were quite a few discrepancies between what the DSM said and what the ICD said. And if you have questions or anything, feel free to plug those in the chat. I also have an eye on my email in case anything comes through there. So feel free to put anything in. I would not claim to be an expert on this, but I did do a deep dive into it. All right. So the second edition, a little over 10 years later, 1968, They broadened these categories, and they were kind of described as like including milder conditions that were seen in the general population. So beyond just the institutionalized diagnoses, this is the milder conditions for the general population. And that included a diagnostic category called conditions without manifest psychiatric disorder, essentially saying, okay, this is within normal ranges, but it's worth getting an exam by a psychiatrist. And this was often noted due to stress. So I'm kind of thinking about what we have now. The kind of adjustment disorder that we think about, that maybe is kind of where that came from. The conditions without manifest psychiatric disorder. So kind of normal ranges, which I think, to be honest, we could probably use more of that now, just noting the kind of natural way that symptoms may show up, but don't necessarily meet the criteria for a full diagnosis. And in the second edition, it was more similar to the ICD, which was at that point on to version 8. So, in the time that it took us to get our second version of the DSM, they were on to their 8th edition of the ICD. So that's 2 ICD editions in the time that it took us to update the DSM once, just as a heads up. And then we head into the 60s and 70s, where there was a bit of critique around psychiatry, around mental illness. There was some skepticism on the legitimacy of psychiatry as a medical discipline. And I don't think that that's too far off from where we still are. They noted that there was a lack of clear differentiation between mental health and illness. So, mental health, just kind of everyday mental health versus what is actually meeting criteria for an illness, a condition, and a low reliability of the psychiatric diagnoses. Meaning, if 2 people or 5 people or 10 or 15 all were to try to use the same diagnostic criteria and come up with the same answer, that was not happening. It wasn't reliable between different providers using the same criteria. There was also reduction in some of the funding for psychiatry. So this was federal government and insurance providers. Again, this doesn't sound too different, like from where we were in the 60s and 70s. And they claimed that it was due to non rigorous investigations, meaning research and assessment, as well as, quote, unnecessary healthcare expenditures. Not much has changed. That is a key reason for funding being pulled from our field, is that there's a skepticism around, can we actually diagnose? Do we know what we're talking about? Are these real diagnoses? We're not doing enough research, or it's not valid, and too much is being spent in this field. So that was going on in the 60s and 70s, as is today. And this next one is also not going to surprise you. Non-licensed professionals, so think psychologists, social workers, and counselors at that point, who were non-licensed as medical providers, so they didn't have a medical license, were seen by psychiatry as competitors because they were offering therapeutic services at significantly less expensive rates. They did require proof that a psychiatric diagnosis was present, and that it was like a legitimate disease, is the wording that they use, and that it was being treated as such. So, again, kind of where we're at with probably most of us here being psychologists, social workers, and counselors, seen as competitors, not only amongst each other, but also with psychiatry, and then needing some justification. Why are you providing this treatment? What diagnosis are you addressing? Is there an actual diagnosis, right? So that was going on in the 60s and 70s. And it really led to the third edition of the DSM that came out in 1980. The other thing that was happening between the DSM 2 and 3 is the progression of using psychotropic medications. And by the time the 70s came around, it was regular practice that many people who were getting treated for their mental health would also be receiving a psychotropic medication to treat it. So you've got all this kind of skepticism in place, the hesitancy around our field, and then you have the increase in the use of medications, which led us to our third edition in 1980. And I don't see any questions, so I'll keep going. Just know that I know that this is dense. You can come back and listen to this. If you need to come back and try to revisit some of the information. This is just getting us to our third edition in 1980, where it grew from 182 to 265 different mental disorder categories. And this was in part, they said, to reflect the information that had been gathered through the research, as well as to be more specific about diagnoses. Um, the diagnoses were more elaborate. They had more defined operational criteria. So think numbers like 2 weeks or six of the following or whatever. And exclusions were formulated for each disorder as well. And that's where we get the differential diagnosis that comes in. Also, from the third edition is the multi-axial system of diagnosis, trying to look at clients' presentation in various ways. So, what does it look like for the individual? And also, what can that look like for different people related to any sort of condition? The hope was that this would make it more comprehensive as we look at any one particular person and their condition and how it's presenting for them as compared to other people. We also saw improvements in collaboration between professionals and research studies, which is great and which has been asked of us by this point. But that did mean billions of dollars were being put into government and pharmaceutical companies for the psychopharmacological research. And you probably see where I'm going with that. How does the kind of big pharma or the pharmacology field affect our field as mental health professionals? Like, are we helping them? Are they helping us? I will talk some more about that as well. That was a comment that I got in social media, was about the influence that the pharmacology field and, to be honest, marketing and research has had on the DSM. So I will talk about that. I will address that. The third edition had a revision that came out. This was the first revision rather than going into a full new diagnostic manual edition. This one had 292 conditions in it for the DSM 3R revised. The DSM-4 came out in 1994. There were 297 conditions and continued improved congruence between the DSM and the ICD, which I think is a good thing. If the entire world is going to be doing research on similar topics, my hope is that our diagnostic manual and their diagnostic manual would match up more so than not. The DSM-5 was published in 2013. So it's been a little while since the DSM 5 was published. It had 947 pages and 300 conditions. So we went from, remember that short little spiral bound book that, had a little over 100 into this really thick book, if you get the print version that has 300 conditions. And most recently, the version that we are now currently using is the DSM 5 text revision, which came out in 2022. So the APA notes that the text revision didn't have a whole lot of conceptual changes to the criteria sets. There were just some necessary clarifications to certain diagnostic criteria that had been reviewed and approved by the DSM steering committee, as well as the APA Assembly and Board of Trustees. So there are many layers to how the DSM gets updated, and I will talk about that next. But I just wanted to stop and reflect back on all the changes that have happened to the DSM since it was originally concepted. Um, it's increasing in size, it's getting more complex, and some of the reasons for this were noted as a theoretical shift in conceptualization from a biopsychosocial model, which I think many of us in our programs still use for case conceptualizations, but moved from that into a research oriented medical model for the DSM. And that is why some of the complexities are there. Um, some of the information is increased because of the research. That makes sense. But the focus of the diagnostic criteria has been more so for medical rather than that full wraparound biopsychosocial model. Also, the multi-axle diagnostic system that was created. There are a lot of biomedical findings that were done based on that multi-axle system. So there's the five axes and then the relationship between them. So there's that back and forth between the psychiatric side of things and then the biomedical and how they're applying that in a lab in research. And apparently the multi-axle system was very helpful with that. There, of course, is the inclusion of new disorders, expansion of defined disorders. So that makes sense if they're constantly adding to it, constantly expanding on current uh, conditions, then we're going to have more information. There have been some reorganizations, though. They mentioned these are lateral, so they become discrete, broad categories where some of the disorders have emerged and some have been eliminated. And then there is the descriptive somatic orientation that became the norm of the DSM. So, a growth in the medical model since the DSM 3, as we talked about earlier, why that was with the 60s and 70s. But that descriptive piece is, of course, expanding inside of the criteria and then all the information that comes after each of the diagnoses. So that's kind of how we got here to a certain extent. I will talk about the updates, but that's the history of the DSM in a hopefully a digestible piece of information that you can take in, knowing it's been a while since the DSM has been around. It's changed as far as the reasons for why it has been used, and then the actual content itself has continually updated. And that's where we get into how the DSM updates occur. And I mentioned earlier that there are updates once a year. Every year around September and October, the DSM gets updated and it is put as a PDF on the APA's website. Um, and I think my admin has that link, if you don't mind plugging that in to the chat. And I can also add these in resources later. But if you want to plug that in, put a reminder on your calendar every September or October to go in and check out what the updates are. Because sometimes they're super small. Sometimes it is just a little bit of an update to the text and maybe to the ICD codes. That always happens every year. The ICD codes get updated, and this is how the United States is using them. But sometimes those changes can be significant. And that is especially true when you're changing diagnoses, maybe adding diagnoses, or changing the criteria that is under those diagnoses. Know that anyone can submit a proposal for changes to the DSM. So if you're interested and you're really passionate and see an area of the DSM that is lacking or that could be improved, you can submit a proposal. You can also view and comment current proposals that are on their website. So don't feel like you just have to wait until the next update comes out. You can be involved in that process. I know that they have their own task force and committees that are actually working to push out the updates, but they do take what people submit to them into consideration with those proposals, as well as any comments that are made on potential changes that are being proposed. So we talked about the DSM-3 being influenced by the use of medications and by the mid 70s, really medication was pretty common to have been prescribed for folks with mental health conditions. This was just becoming a normal practice. The way that this contributed to the DSM-3, though, there was a 1965 conference addressing psychiatric classification that was sponsored by the Psychopharmacology Research Branch of the National Institutes for Mental Health. So that right there is a very clear connection between psychopharmacology, where they are sponsoring the conference to talk about any changes to psychiatric classification. That was in 1965. Washington University formed some criteria for operational diagnoses. So we have institutions that are contributing to this. And then there was the development of the research diagnostic criteria, and that's around psychobiology. And again, we're talking about the overlap between the research, the medications, and then the diagnostic criteria as well. So there is a researcher, or I guess it would be fair to say there's a small group of researchers out there who are looking every time there's an update to the DSM to see what financial conflicts might be involved in the changes made to the DSM. So, since 2013, US drug and device manufacturers have been required to disclose any payments that were given to physicians and teaching hospitals. So these particular researchers took the Centers for Medicare and Medicaid Services open payments database, and that's where all the money is shown about which pharmaceutical device companies paid which individual physicians and institutions. And then they connected that to find any conflicts of interest for the folks who were working on the DSM and the updates. They found that 168 individuals who worked on the DSM-5 text revision were identified in the database. Those who were non-physicians were maybe not based in the United States. Those were excluded from the research study. So now we've narrowed down to 92 physicians who served as a member of a panel or a task force for the DSM-5 text revision. So 86 of them served as a member of a panel, and 6 of them served on a task force. And as far as quick numbers here, 60% of panel members and task force members received payments from the industry. So well over 50% were receiving some sort of payment from the industry, meaning related to pharmaceutical and device companies. That's a big number. The payments were most commonly categorized as food, beverage, travel, and consulting. So that probably has to do with conferences that they were involved in, maybe keynote speaking, other things like that. Food, beverage, travel, and consulting. But it's still a pretty large number. We're talking about millions of dollars that are being given to these, probably not any one particular individual, but being given to these individuals as a whole. There were some good notes here. The percent of panel members with industry support was similar between the DSM-5 text revision and the DSM-5 and DSM-4. So over the years, thankfully, the number hasn't like increased too much. It's about the same. And they did find that with the task force, there were fewer conflicts of interest. So that's a good sign as well. But 60% is still not a great number, to know that they may be influenced in what they're suggesting for revisions. The researchers did want to note, like, this is not unique to psychiatry or mental health or even the United States. So the National Heart, Lung, and Blood Institute has also had these issues. And in France, the French Health Authority had similar issues. So this is not unique to the United States. It's not unique to the DSM. It's not even unique to mental health. These types of conflicts of interest occur everywhere. And unfortunately, millions of dollars are in the background of the DSM. So we'll see what happens with that. Thankfully, we have researchers who are willing to do the work to find those conflicts of interest, point them out. If you're interested, I can provide a link to that study, and they actually have graphs to show which industries have the greatest percentage of members who were paid, as well as which industries had the greatest amount of money that was paid into those members. I also have it written down. So, like, if you want to know about it before we leave today, I would be happy to pull that up and talk to you about it. Um, but yeah, lots of work going into updating the DSM constantly in the background. You can contribute to it, you can comment on it. There are task force, there are committee members that are constantly meeting and trying to improve the DSM. And I think if you're passionate about it, I highly recommend that you contribute to it as well so it can continue to be better. So we'll look at some of the ethical and cultural considerations when applying DSM criteria and actually making any diagnoses. I'll talk about what the DSM has, and then I'll talk about some of my, own thoughts and questions that I have when I'm applying DSM criteria. So, first thinking about the DSM, I mentioned earlier, for each diagnosis, there are a section or sections after the diagnosis with information on culture and how a particular diagnosis may show up or how the symptoms may show up. Um, there is also within the DSM an entire chapter called the Culture and Psychiatric Diagnosis chapter. And this is about integrating culture and social context into the clinical diagnosis. There are key terms. There's the cultural formulation interview. If you haven't looked at that, I'll talk a little bit about that, and some cultural concepts of distress, which I think is really important with any sort of diagnosis that we're making. So I'll come back to that. If you don't have the DSM, then you can actually find the cultural core cultural formulation interview on their website as well. So they have an interview that you can print yourself, you can use as a DSM. There is one for the client, and then there's one for the informant. So if you have someone else who's giving information on the client and how their symptoms are presenting, as well as like their background, their family dynamics, the environment that they're in. So it's not just, has this been happening for 2 weeks or more? Has this happened in the last 6 months? Which of these three are happening right now? It really is more inclusive of that biopsychosocial model of doing an assessment for a client. So if you haven't checked that out or you're not using it, highly recommend you do. It's not a requirement by any means, and you don't have to use the whole thing like exactly as it's written, but it includes questions, like questions that you can use. You don't have to create them. Isn't that great? So you have questions that you can use during your assessment. So, highly recommend you check that out. Also, on the website, there are some alternative versions to the core cultural formulation interview. So, this is again where I think you can take in multiple perspectives and create your own. There are also supplemental modules to that interview if you want to go more in depth into how to use the interview and what sort of questions, why they ask the questions that they have, things along those lines. Definitely not something that I remember our program talking a whole lot about. And I think that that would have been helpful maybe as kind of a baseline for doing a diagnostic assessment. So I mentioned distress, and so I want to come back to that because I think for me, if you look at any diagnosis, it basically says, is there any significant distress or impairment? If you can't answer yes to that, then the criteria is likely not met. So if you step back for distress, then you could ask yourself some additional questions. So these are Dana's opinion. These are questions that I often ask myself when I'm doing a diagnosis. How do we determine which emotional or behavioral aspects are problematic and problematic to who? Is the client feeling distress? Is the client noticing any sort of functional impairment? Is it more important that I notice the distress and I can point it out or notice the impairment? Or is it really about the client and what they see as distress in their life? What might be seen as distress is actually just an extension of normal behavior, normal human behavior any of us might do at any given time or day. And what is simply unique to that particular person and how they present. So that little question of like, is there significant distress or impairment is much more complicated than a yes or no question because there's so many layers to what distress means, what it looks like for different people. Um, that's why I think it's helpful to go back to the functional impairments in the different areas of life. So looking at work, school, family, relationships, social, executive functioning. I have a little checklist of that for myself to go through with the client to talk about, like, okay, which of these areas are maybe we seeing some distress or some impairment. I think another really important question to ask ourselves when we're diagnosing is why. What is our why for diagnosing a client? And really, what I mean by that is, how is this diagnosis going to be helpful specifically for the client? Like, in what way would this diagnosis be helpful for the client? And equally as important, how might the diagnosis be harmful to the client? Just because they're meeting criteria, does that mean we have to diagnose it? Just because they met the criteria for 3 of these diagnoses, does that mean we need to diagnose all 3 of them? That's a question that we should be asking ourselves, and I think this leads into our codes of ethics. So, what does your code of ethics say about diagnosis? And I'll start with one that is very, very clear, has a whole section on this. The American Counseling Association's Codes of Ethics, Code of Ethics. They have a whole section on diagnosis, and the subsections are about proper diagnosis, cultural sensitivity, historical and social prejudices in the diagnosis of pathology, and refraining from diagnosis. They put right in there that if it's going to be harmful to the client, don't use the diagnosis. So they are encouraging us with that code of ethics to really think through the why of this diagnosis, the helpfulness of this diagnosis, the potential harms of this diagnosis, and some alternatives. I looked up social work and marriage and family therapy, and I found that in both of those codes of ethics, there wasn't anything really specific to diagnosing in the way the ACA has their code of ethics. The American Association for Marriage and Family Therapy does talk about competence related to diagnosing, and it does hold many of the same tenets as the ACA. So there is a point about competence. Are we competent? And not just competent to diagnose in general, because I think that feels sometimes like a checkbox, like, oh, well, my state in my license, I can diagnose, but like, are you truly competent? Have you had the research, the experience? Have you gone through the process of each of the diagnoses that you may be giving? I'm not saying learn every single diagnosis and try to be 100% competent in all of them, but that's part of competence too, is knowing your limits. Knowing when, okay, this diagnosis I don't know as much about, so it'd be better if I refer to someone else who can do that type of assessment. That may not necessarily mean refer for all services, but if it is important to rule in or rule out a diagnosis and you're not competent in that area, how can you involve someone else in that assessment process? I found an interesting article from the New Social Worker magazine, and it has an article about the DSM and the ethics of diagnosis. The whole article is on that. And it really emphasizes from the National Association of Social Workers Code of Ethics the following regarding diagnosis: respect, empowerment, professional competence, and duty of care. And once you wrap those in, and if you go and read that article, it almost overlaps exactly with what the ACA is saying and the tenets of the American Association for Marriage and Family Therapy. So there's a lot of overlap, even if it's not said as directly as it does in the ACA. Once you dive into what each of those areas mean, then you kind of get tied back into the same thing. So, for example, empowerment. How is this diagnosis going to empower the client to do anything? Maybe it will, and that's great. Okay, so how? um Respect, like, are we respecting our clients for choice and knowledge? Are we talking to them about the potential diagnoses, the criteria that we're seeing met, and asking them about it as well, rather than it being this kind of unilateral decision that we made, and that sometimes people in our field are not good about sharing with clients. Let's be honest. Often people do not tell clients, hey, this is a diagnosis you have, and so they don't even know until they get like an evidence of benefits or super bill or something that has a diagnosis on it, or maybe they're referred to another provider and they don't even know that they have that particular diagnosis. So Dana's suggestion here is just to be really clear with clients, really transparent with clients about what diagnoses you're considering, why they would need a diagnosis in the first place, how it might be helpful, getting their feedback on what you're seeing. Again, probably a whole nother training for another day. If you're interested, let me know, and I can talk about kind of my process for ethically diagnosing. But our code of ethics, they all really relate back to that, back to first and foremost the client and their welfare. Okay, get off that little bit of a soapbox, and I'll move on to the question that you had submitted around Z codes. So, when should you use them? What are the benefits? What are the drawbacks? Things along those lines. And I'll be honest, there was a lot of information about the DSM. There was not a lot of great information about Z codes. So, I did take what I could find and pulled it all together. They appear to become available in fiscal year 2016, and it is noted that they're not adopted that widely. There's some limited adoption because there's not a whole lot of clarity on who can use Z codes, who can document them, why they're helpful, and just generally an unfamiliarity with Z codes. I don't think that my program went over Z codes. I don't think we did. That probably was not gonna be on our, exams, the CCE, the NCE, the NCMHCE. I don't think they asked about Z codes. I think they asked about diagnoses and diagnostic criteria. They didn't really ask about Z codes. So, what are they? They refer to factors that influence someone's health. So, not just mental health, they are used throughout all the different aspects of health, and it is affecting their health status, and or affecting their need to contact health services. So it's not a classifiable disease, condition, injury, or some sort of external cause of something, but it's still a part of why they are contacting a health provider and maybe why they are presenting with particular health concern. Some of the examples that I saw, especially for like our field, were like homelessness, for example, or some sort of family dysfunction, something along those lines. That's not the exact verbiage, so don't quote me on that. But one source that I read indicated that Z codes were originally V codes. So Z codes and V codes. And these are about specifiers, accurate billing, and insurance reimbursement. So, that's just an aside. I don't know if that how 100% true that is, but that was what someone had kind of indicated, that they used to be V codes and now they're Z codes, and these are the reasons that they've been used. And the majority of what I found, honestly, with Z codes was around research and equity in health care. So they are considered the social determinants of health. And the World Health Organization that I mentioned earlier estimates that these social determinants of health account from 30 to 55% of all health outcomes, which is pretty huge. So these social determinants of health, which are located under the Z codes, if we collect them and we document them in the research, it can help improve equity, healthcare delivery, and research. Previously, and I think probably still to this day, they're not seen as a high priority to note. They can be used when you're diagnosing, when you're planning treatment, when you're submitting insurance claims, and often they're not required. So that's where that priority piece comes in because they're not required. It doesn't feel like they're as big of a priority. If you look at the Centers for Medicare, Medicaid, um, I don't know why I'm blanking on their name, but CMS has guidelines for coding and reporting for Z codes. And they have in that it's updated every year. It was a little hard to find at first because I think at one point it was under the Department of Health and Human Services and then it got moved over to the CDC. So just make sure that you're using the most up to date, which the last one that I saw was for fiscal year 2026. And it will actually indicate the years and dates that you're supposed to use it for. So CMS notes that Z codes may be assigned as appropriate. So, again, not required, assigned as appropriate to further explain reasons for presenting why a client is presenting for healthcare services. And that can include a transfer between healthcare facilities or to provide additional information relevant to that particular encounter, so that particular service that was being provided. Within that official guideline for coding and reporting, there is a list of codes that are identified as principal or first listed diagnosis only. Most of them are secondary or can be used as either or, but there are some that they note that can be principal. Now, that's for all health conditions, it's not specific to mental health. They do have one section, category 10 is related to counseling. So they indicate that these counseling Z codes should be used when a patient or family member receives services in the aftermath of an illness or injury, or when support is required in coping with family or social problems. So again, it's not required. They don't even say that it's necessary. This is optional. And they do note if it can be listed as primary, secondary. Um, One of the things that was highlighted is that Z codes are not procedure codes. So you do have to have a procedure code that accompanies the Z code. Procedure code is what service did you provide? And then you would add on a Z code to that as well. Um, this is supposed to help with patient history. So it's more available to us than it would be to the insurance company or anyone else who might be seeing the Z code. So the Z code can help to determine any appropriate external cause for whatever the condition is. Let's see. They do say that you can assign as many codes as necessary to explain the encounter. So that's another thing. It's not required, but you can list as many as you'd like if that is something you decide to do. And I really think it's going to come down more so to research as far as how it's going to be helpful. However, there are some benefits to using Z codes that were mentioned. I'm not going to say this is Dana's opinion, but these are just some things that I collected. It could help clients better understand their condition and reasons for seeking care, and may hold less stigma than an actual like F code diagnosis does. So that's helpful. And we're still needing the F code if you're applying a diagnosis for care. So if you've got both, it would be helpful to explain both. But in this case, they're saying if you're just using Z codes, then it could better help the client understand and could be less stigmatizing than an actual diagnosis, which I think is a fair argument to be made, but it depends upon why you're using it. one of the things that one of the whys is alert the insurance company to the detailed needs of the client. Again, they can't always see all of your documentation. They're not going to know all the information that you have. So, this is a way to let them know what else is going on behind the scenes. Like, why is this diagnosis being given? Why is this person receiving treatment? So, kind of letting the insurance company or whoever that third party payer is know why they're receiving that care. Some of the other benefits could be that it helps other professionals or specialists know more about the need of the client without needing the entire client file. So, this could be especially true for children with school staff or pediatricians who are able to see the Z codes. They get a little bit of a snapshot into that child's history and or why they are coming in for services. It could be helpful with other mental health providers like psychiatrists or any future therapists that a client sees. Again, they've got a snapshot of the history without needing the entire documentation. Also, neurologists or endocrinologists, other specialists along those lines, may get some insight into the client history. That probably not as much for us, although neurologists maybe. Just thinking through who might share our Z codes, meaning who else might also use the same Z codes, knowing that we have a much shorter list that we use versus like an endocrinologist might use. But it could be helpful if they are gathering the information on the client and knowing a little bit about their background. So, one example of that is if you put the Z code that shows the history of childhood abuse. That is a specific Z code. And then anyone who reads that Z code knows that history about that person. So that leads me right into the drawbacks. This could lead to a confidentiality breach. It could lead to a breakdown in rapport with the client if it feels like you're sharing something about their history without letting them know. You're providing personal information without any context. The other person receiving this doesn't know, like, when was the childhood abuse? What happened with the childhood abuse? How far have they come, in addressing the new trauma from that? Like, it doesn't provide any of that context. And a couple of examples of these that could be concerning is like problems with unwanted pregnancy or child in welfare custody. No context to that. That feels to me a bit too invasive to just randomly slap on a piece of paper and then hand off to another provider or an insurance company. Um, Speaking of insurance companies, it's unknown. No one had a clear answer in all the research that I did if insurance will pay for services for Z codes only. I know there are a lot of people out there who say, no, they will not. And maybe that's true. But also, I didn't get anything that said that they would. So that could be a possibility. I would check if that's really important to you. I would just check in with the insurance company if they will use Z codes only, meaning no F code, no diagnosis, because of course you have to have the procedure code. So you're adding the Z code to that. So I won't say for sure whether or not that is true on if they will pay for Z codes only. I would just say talk to those insurance companies or other third party payers and try to find out if that would be appropriate. In that case, I would definitely use a hypothetical. I would not put a specific client out there. I would just say, hey, if I happen to have a client who didn't meet the criteria for an F code, but a Z code, how would you pay for that? But then also, again, talk to your client, let them know your process, what's going on, that they may or may not pay for it. So that's a whole decision that you'll need to make with the client. But if you do decide to use them, identify the category in which the client's stress originated or is maintained. And if you have multiple stressors, so you're listing multiple Z codes, list them in order of influence. So if you do use them, just be sure to identify where their stress is coming from and also list them in order of influence from the most stressful to the least stressful. The best practice I found was having a F code as primary and a Z code to supplement the F code and the procedure code. So, yeah, that's hopefully some helpful information on Z codes and how to use them and benefits and drawbacks. of those Z codes. I don't see any questions. I'm happy to dive more into some of the specific areas I looked at with updates to the DSM on certain diagnoses or certain sections of diagnoses. So if you're interested in that, I can talk about it. I do talk about it in many of the other trainings I do, so I didn't have it built into today's discussion. It felt heavy enough without going too much into the history of specific diagnoses. But if there was something you had a question about, I'm happy to answer that. Um, I don't see any questions in the chat or in the email. So I will just hang out here for a little bit and plug some of these resources in the chat. And then I'll also have them in the description box. I know YouTube uh, comments can be weird sometimes. So if you're having issues sending something, don't hesitate to send it to me via email later or add it after the fact. It's totally fine. Of course. Yeah, I'm just gonna add the links in the resources later because I don't think the whole link is gonna go into the chat. I will include the ICD-10 official guidelines for coding, some of the online measures that I mentioned, some of the research articles that I used. So if you're wanting to look more into each of those individually, you'll have access to those later. But I'm here, so if you have questions, I appreciate all y'all being here. I see you saying thank you, and I'm happy to do this. I really enjoy doing it. Um, yeah, just appreciate you showing up. If you're typing out a question, take your time. Um, don't feel like you're rushed. I'll hang out for a couple more minutes. Absolutely. Hope y'all have a great day as well. Thanks for being here. Always love seeing your names and faces of those of you who I recognize. If you're here after the fact, you can always leave a comment or send me an email with any questions that you have. I'm always enjoy hearing from you all and try to answer, either in the video comment chat or via email if you do reach out. And if it's something really helpful, I try to share it with everyone else as well. I think that'll wrap us up. I don't see any additional questions. So y'all have a great rest of your day. And I look forward to seeing you hopefully next month. Thanks, y'all.